Good afternoon, everyone, and welcome to our Culture of Safety orientation training. I'm Eric Gregg. I'm from DHS in our Disability Services Division, and I lead our Culture of Safety efforts, which we'll talk about more today about what that looks like. But the bulk of today's training will be around the kind of the principles and values that inform this sort of initiative and incident review model. And so we'll dig into some of the learning objectives in a bit, but I wanted to start by introducing um, Charles and Scott, who are presenting with me today. Uh, I'll let them introduce themselves in a bit. So I said, I'm Eric Gregg. I lead our culture of safety efforts, and we've been doing this since about 2019. And so we'll share about that evolution and where we're at in a bit. But I've been with DHS for about 6 years, and um, yeah, just excited to be here with you all today to share more about this. I'll go to Charles and then Scott.
Good afternoon, everybody. I'm Charles Young. I'm the Legislative Coordinator for Disability Services Division. A lot of the work that's being done in the pilot will culminate, I think, ultimately in perhaps some legislative changes. And so on board as we watch to see what comes out of the systemic influences that are found through this process. And you're going to learn all about that as we talk through today's webinar. So thanks, everybody.
Great, thanks, Eric and Charles. Scott Shefsky, I'm in the Community Capacity and Positive Support team. I do a lot of work in responding to service terminations, and I'm also one of our safety analysts and obviously trainer in partnership with Eric and Charles and several other folks. So good afternoon, glad you can make it.
And then last but not least, we do have some WebEx support. Anna is supporting us in the background. They put some information in the chat as well about a survey. So it's called Slido. Is like the name of the poll or survey function. So if you haven't seen it yet, if you look for it towards the bottom of your screen, it might pop up automatically, or you might have to click some dots in the bottom right corner to pull that up. And so we've got 3 poll questions for you to complete, asking if you've attended a training, what kind of role best describes you, and then what region you're from. So this map here lists out some of those regions. But back to Anna supporting us. So if anything WebEx comes up and you're having some issues with something, you could put tech in the chat and ask that question, and they'll be able to help you with that. And so thank you, Anna, for being here to support us on the technology side of things. So I'll give you a moment to reply to or respond to this question, or give you a chance to reply to this survey. Look at this part of the state, where you're from in the state, and while doing that, I'll just kind of start a little bit of an introduction. So part of our kind of purpose here today is, like I said, to inform you a little bit more about what is this culture of safety initiative and effort that DHS is doing. Some of you have maybe attended one of these in the past. Most of it's the same. There's a little bit more information, as Charles alluded to at the end, about what we're learning and where we're at with some of that end part of the process in this review model cycle. But ultimately, we want to share more about both the model, but we also want to increase awareness about this approach to when incidents happen, when work happens in human services, whether you're a provider, a lead agency, some other kind of organization, could even be a person or family that's involved with directing services and working with staff. Ultimately, we want to use this approach when the main use of this approach is when things aren't operating as we would wish, whether there is something formal like a critical incident, or you just have something that keeps happening, but you're not sure why. Um, don't really have an understanding of um, why you keep having the outcomes that you wouldn't want, or you want more information um, about a specific incident or a specific problem or issue. This approach gives you a framework and a solid kind of value and approach to uncovering more information about what's happening, why it's happening, and how it's happening. And so it really helps you study problems and issues to inform then solutions. So uh, as we walk through, you'll really hear us talk about like pausing and being able to gather more information. That's sort of the premise of this approach is let's study more about the problem before just coming up with some solutions that we're throwing out there, kind of throwing at the wall. We want to make sure that we fully understand it. So I'm going to cover the learning objectives here, but give a last kind of call on. Sorry, let me go back to that. Last call on the survey. We'll close it in just 10 seconds. So please go ahead and add your responses. Again, it's Slido is the where the survey questions are. And Anna, if you would go ahead and close the poll, we'll just take a look at what we have for responses. I think this portion of our WebEx is it's at least a newer feature for me. It might be a newer version of that. Let's see if I can find the results. I'm not able to see results yet. All right, I'm getting some finding it here. It looks like we have around 95 attendees. We had looks like 85, I think, participate in the survey. So for question 1, one second. Or Anna, if you have the results, if you're willing to share them verbally, that might be easier. I'm still not seeing them on my end.
Yeah, sorry, I don't know why they show up. For the first question of have you previously attended a culture of safety or collaborative safety training or presentation? 25% of the people said yes, 75% said no.
Okay.
For the second question of what roles best describe you, we have 2% advocates or self-advocates, 4% family member, 14% provider agency, 56% county or tribal lead agency, 24% state agency or government, 2% medical providers, and 2% other. And then for the last question, what region are you from? We have 13% in regions 1, 2, and 4, 5% in regions 3, 23% in regions 5 and 7, 15% in regions 6 or 8, 14% in regions 9 or 10, and 30% region 11.
Excellent. Thank you for reading those out. So a lot of people who haven't attended a training before. So welcome to everyone, but especially those that haven't heard of it. We hope you pick up some new information. And for those who have attended a training, glad to have you back because we found ourselves as we train in this material and we attend different like other trainings and trainings as we were learning more about this approach is that we are always picking up something new, especially because our default as humans isn't isn't the approach that we're talking about. We've all found that a lot of this information that we talk about today and the values behind the culture of safety make a lot of sense. A lot of support for it, but that it's can be a constant kind of journey of teaching ourselves how to utilize some of this approach. So I'd love to hear that we've got a good representative group. We've got, I think, every role had some people that identified with the roles that we listed and every part of the state. So great to have all of you here. All right, so the learning objectives, same as what was in the training registration information, but hoping that as you leave today's training, you'll be able to define some of the safety science principles that inform this culture of safety approach. We're going to use sort of a compare and contrast between kind of an old approach to viewing safety and new approach. So to be able to kind of identify what each of those look like, and we're working towards a shift to more of a new view approach, but knowing what the old view is can be helpful to recognizing our efforts to try to adopt more new view kind of a lens. After we cover the basics of old view and new view and some of the safety science principles, we will dive into how the Department of Human Services and the Disability Services Division is using the incident review model. And so you'll be able to hopefully be able to describe how we're using it and what it looks like. And then part of us sharing that is both to update what we're learning and what it looks like, but also, especially for those that are within a provider or an agency role, some of the main parts of our incident reviews is engaging with those parts of the service system. So this would be able to inform you if you were asked to participate in an incident review, why we're doing it, how we're doing it, and what would be the ask of you in any of those roles. Some general housekeeping about today's training. It is from 1 o'clock to 4 o'clock p.m. Central Standard Time. We will take a break around the halfway mark, about 12:30 or so. The session is being recorded, so it will be available via archives in TrainLink and can be accessed after today's training. Everyone is automatically on mute through as you join, and you aren't able to unmute just to make it easier and less kind of confusion if someone accidentally unmutes. We've disabled that setting, and so we do look for some interaction throughout, and so please utilize the chat as we'll ask some kind of discussion questions, some yes/no questions, or if you've got comments or questions that are outside of what we're prompting, feel free to make those through the chat, and we'll either respond verbally or through the chat to those. A couple things about WebEx logistics then is finding the chat. Hopefully it's easy to see. It should be at the bottom right of your screen, a button that says chat that's right next to participants button. So that's good to know where it is. If you're having any kind of technology issues with connectivity, best case scenario is their best kind of solution would be to close out and rejoin. You could look at joining via phone. Sometimes that provides a more stable connection than internet. Other than that, we do have one video a little later in the training, does have captions. And so just an FYI that for audio wise, there'll be a video as well. And then PowerPoint slides were sent ahead of today's training. So look for that in your email from DHS DSD .learn at state.mn.us PDF of the slides. Just a note on that, if you're following along with the PDF, It isn't exact one for one of every slide. This curriculum and kind of presentation is created by an organization called Collaborative Safety LLC, and so they asked that some slides that we just redact some of that. So some of that's there, and might just be 1 or 2 slides that you have to forward through to stay on track with us on the screen. Charles, Scott, or Anna, anything else housekeeping before we jump into the training?
Covers everything from my perspective.
Yep, all set.
Okay, great. A final thing, you heard it me just reference collaborative safety. You maybe saw it in the training or the survey at the beginning. So you'll hear us primarily use culture of safety. That's the name of this kind of training and approach that we're utilizing with the incident reviews. But Collaborative Safety LLC, the organization that created this incident review model, when we first started this project back in 2019, we started by calling it Collaborative Safety. But then as we invested in knowing, okay, we're going to really test this out and pilot this and develop some trainers and jump into this incident review model, we created our own name instead of being the same as the contractor that we were using. We developed the name Culture of Safety. So if you've heard of someone reference collaborative safety or you hear culture of safety, they kind of mean the same thing. Some organizations that are using this model call it culture of safety. So just want to clarify that language use. If you hear anyone use that, usually it's meaning the same thing as this approach with culture of safety, or at least it has the same values and same kind of intended use. So as a last slide before we jump in is just that there is in the beginning slides here and some of the media slides and articles and video, there is some examples of the stories that relate to like incidents that relate to child abuse, child and adult death, and domestic violence. So we wanted to give that warning that those are some of the examples used to portray when incidents happen. What do our responses look like when we compare it from the old view to new view? So we'll give a forewarning ahead of the video of what it's about or any specific content. Nothing's real graphic or gruesome, but the topic can be triggering or traumatizing. So we just wanted to let you know that ahead of the training. All right, so I'm going to turn it over to Scott to cover human services across the United States.
Well, thanks, Eric, and good afternoon again, everyone. Hope everybody got their kids off to school. I don't have any, so I have more free time. That's not a dig at all. It's just that big transition with the weather, Labor Day, State Fair, all that stuff. So thanks for bearing with us this afternoon. So again, I'm Scott. I work in disability services. I've actually worked in the field for 30 years, and I found this work in particular fascinating because I think historically we've had a very reactionary type system when there's problems. You'll hear Eric and I and Charles talk about this blame that occurs within our system, and it's really a stigma, I think, that perpetuates. And my hope is some of this work can change the conversation a little bit. And so one of the first examples that we talk about this work is we look at through the lens of the media and how the media really portrays human services across the US. And we're also going to have some examples that are outside of human services a little bit and some that are related. So I'm just going to jump in. Some of these examples, I'm going to go a little bit quick because some of them are short, but I'm also going to, you can go to the next slide, Eric. But some of these I'm going to read just because if people can't see the screen real well, I want to make sure that everybody can can see and hear the content as best as possible. So we're just going to focus on the news. And, you know, when you log off tonight, and if you watch the news religiously like I do, look for some of these things as we have this discussion today. It really changed the way I view the media quite a bit when I started doing this work as a safety analyst and trainer. But this one, you know, the Tribune watchdog, suffering in secret. I'm putting emphasis with my body language. So if you can see my camera, you'll see what I'm emphasizing. Illinois hides abuse and neglect of adults with disabilities. Okay. Next slide, please. This one, you know, these are just ominous pictures of grave sites and community homes and some of the articles that we see. You hit the next slide. Here's a big one. And what does the media and public often want to know after a critical incident? And I'll just pause and say, if I'm looking to the right a little bit, I have a couple screens, so I apologize for that, but I'll try and make some eye contact too along the way. But yeah, failures of care. Who's to blame and how will they be held accountable? There's a lot of accountability and blame in our system, as I mentioned. Okay, next slide. I have a transition slide, but really, you know, it is a common cycle. I've been doing this work through the, you know, since the probably early 90s, to kind of date myself a little bit. But I've seen cycles, but I do want to say, historically, we've come, you know, from, I think, some really dark moments to some really good things in our robust home and community-based waiver system. And I'm hoping discussions like this today and your engagement will pull us out of that cycle. And that's a really good time to hit the next slide, please, Eric. And thank you for doing that, so I don't have to worry about buttons. So, you know, really across the United States, no matter whatever state you go to, you'll kind of see the same pattern. If we start up, you know, continued budget cuts over time, followed by high profile critical incidents, you know, and then there's that intense media scrutiny and legislative activity. To work in public policy, saw that a lot. Someone or some part of our system gets blame. And what we do is we like to throw more money at it into the system, and it usually creates these quick fixes. You'll hear us talk about that in a variety of ways that really don't result in sustainable systemic change. There's just these consequences that occur in our system, and then, you know, if this circle was moving, it just kind of moves through time in this continuum. And what you'll see frequently here in our discussion is we do reference child abuse and death when covering this cycle. Those are the things that really illuminate in the media. And I think, Eric, I can't remember if you mentioned this, but this work, our culture of safety, collaborative safety work, did start in our child protection safety and permanency unit, and then it shifted. We adapted it within the Disability Services Division, and really it's been amazing, the people that have engaged in this work. That's why I'm excited to see 108 people on here, and you know, at least 75% of the people, according to the poll, haven't engaged in this work. So I hope you find it interesting. Thanks for that. If you're having trouble seeing the slides, there's just periodic chats, and anytime you can pop information into the chat too. Hit the next slide, please, Eric. So here's an example of just along the lines of what I'm discussing. Budget cuts lead to loss of staff. You know, this is a governor cutting nearly 500 positions, and I'll just read this quickly. The Department of Children and Families is cutting nearly 500 positions to save the state $48 million. And this particular governor tries to balance the state budget and slash that spending by $4 billion. And then the secretary here said critical services. Whoop, can you go back for a minute? Thank you. About half the positions will come from 3 state hospitals, Florida State Hospital, Northeast. And again, this is an example of really a quick fix. We'll cut the budget to be able to deal with other things, and what's, just start thinking about what's the overall effect on our system as we move forward. Next example, this will be a little heavy, just warning you. So another child's death. This is a Florida high-profile incident. For the fourth time in 6 weeks, as the media points out, the State Department of Children and Families is investigating the death of a Florida child who only weeks or months earlier had drawn the attention of agency administrators. The latest to die is Ezra Raphael, age 2. Police say they were summoned to Ezra's home at this location in Miami Beach to check a sick and unresponsive child. And when the paramedics arrived, police said in a statement they found Ezra unconscious on the dining room floor. The toddler was pronounced dead shortly after he arrived at the medical center there. Hit the next slide, please. Again, there's the headline: Florida's undercount of child abuse deaths. State says abuse and neglect deaths are receding after a spike. But are they? And if so, how much? A closer look at the numbers. And so deaths are pretty heavy, but think of other critical incidents too. You know, are they really counted to show the big picture of what we're seeing in our system? Because if we have this data and a better understanding of what's occurring in real time, and I'm jumping ahead a little bit, we might get a better understanding of what some of the long-term, you know, remedies or things we can do within our system that can be helpful. Next slide, please. Okay. Florida worker leaves. When there's a critical incident, I think they call it kind of, I don't know if you're like me and grew up in the 80s, there was a show called The Fall Guy. There's always a fall guy in situations. And I'll just pause to say, it doesn't mean there aren't bad apples, okay? In other words, people that do deserve to be fired or leave, but sometimes there's unintended consequences and environmental factors that lead to blame, which then leads to people leaving. And sometimes they're good people, okay? But here's just an example. I'll read it quick. Amid an escalating scandal over the recent deaths of 4 small children who had a history of involvement with child abuse investigators, Wilkins is leaving the agency to pursue opportunities in the private sector, that he said in a statement. And the other individual, who became the governor's longest serving agency head, served as secretary of the Department of Children and Family Services since Scott's inauguration, pardon me. But in recent months, Wilkins became mired in a simmering controversy over the deaths of 4 youngsters in a 6-week-long period. We don't know a lot of the why to the story here, right? But one of the, you know, Miami-Dade and Broward counties, a 5th child, also from Miami, nearly died from a lacerated liver. Again, heavy stuff, and the infant suffered a broken thigh bone months earlier. So there's a lot we don't know by some of these, you know, paragraphs and information that we're seeing, you know, quite abruptly in the media. And what you'll hear us talk about it later, really, what's the second story and understanding of where was the system's response, and not so much to blame the system, but why, what's happening within our system. The one thing I'll just say, just kind of a side note, is that I think we can all just admire for a moment the complexity in our disability services system. It's very hard to navigate. There's a lot of moving parts. Good things don't always happen. Bad things always happen. But again, peeling that onion to have an understanding of why is a lot of what this work is about. Next example, please, Eric. Tallahassee. I don't necessarily like this word, but with, you know what, speed, the House and Senate budget negotiators met Tuesday and agreed to millions of dollars in new money for child welfare. Again, like that wheel, they're throwing money at this. It doesn't mean that money doesn't fix problems. It would fix a lot of my problems, but the point is, money doesn't always fix problems, and we don't always have a good understanding of the system. And then, you know, far below what children advocates had hoped, but more money to follow than either chamber had originally thought. The proposal also gives the governor only about 21 compared to 39 that he had asked for, and the agreement may be only preliminary. And, you know, so there's a lot of things going on in this story here, and not a lot of understanding of the why and what are the moving parts as negotiations occur. Next slide, please. We have another wheel. So our system does engage in this circle. If we want to push, you know, this is safety versus autonomy. If we want to push autonomy, we have to find ways not to punish providers. I think, and I know my colleagues will say this, I don't think anybody, in particular people on this call in our system and over the last 30 years of people I've worked with in human services, showed up to do this work to do a horrible job, or have bad outcomes, or have critical incidents occur, whether they be medication errors, not keeping an eye on somebody and they elope and something happens. I think there's really good intention, well-intentioned people. It doesn't take away from a group of bad apples, but, you know, as we look at this wheel, you know, we want to push autonomy to find ways not to punish providers, come up with, you know, we come up with a lot of elopements and service terminations in our work. Like I mentioned earlier, that's what I do. Try to understand what were the events that occurred up to that service termination that yielded that provider to have a concern. Is it behavior? Is it not enough support? Is it, you know, just workforce shortage related matters? There's just, again, having those branching conversations to understand that why when we talk about service terminations, and that is one of the critical incidents that we are reviewing with this process, to really understand that backstory and get upstream. And it's something we have to work at addressing throughout many parts of our system. So again, this wheel, it's just kind of a continuum, okay? And it really looks at that blame and penalize aspect. And we'll shift to responses in the old view, Eric. So incidents and system responses in the old view. This next one's a headline, just gives you another example. Judge blames social workers' failure to do their jobs for 2,000 death of foster children. I probably talk on average between 15 and 20 social workers per month, and we have great conversations, and I've talked to people over the decades, and I can only think, I was just thinking about this earlier today, I can only think of one social worker that I've run to over the thousands that I would, you know, seed out as a bad apple. But again, there's an incident occurs and someone has to get thrown under the bus every time without an understanding of, you know, what was going on for these social workers. You can put it in the chat if you want. How many social workers have over 80 people on their caseload? How do you manage, you know, let's say with all of those 80 people, there's 250 critical incidents that you have to review and respond to. There's a lot of challenges in our system with overload, overwork, workforce shortage related matters. You know, but there's the headline: the First Nations father child, Wigula Potts, was killed by his foster mother in January 27. She was later convicted of manslaughter. And again, the judge is blaming the social workers for failure to do their jobs. Okay. What else was going on as we look back at this? Okay. Next slide, Eric. So the judge said none of the workers addressed their minds to what needed to be done to save this kid. His death was a direct result of the fundamental failure of everyone connected with this child to do their jobs. No one followed the rules and procedures that were in place. Really? So no one followed the rules and procedures that were in place. We have so many layers of policy and procedures from the provider level, the county level, the state level, the legislative level. Like I said, we have a very complex system. And does our entire system conspire against this kid in this situation? It's just a question I'm throwing out there as we go through these examples to kind of, you know, look at these media examples and look at that system response. Next slide, please. Another example: senior died after nurses gave him another patient's medication. How many people here, and you can put it in the chat or not, whatever you feel comfortable with. I can't even see it at the moment, but I'll click it open just in case there's a response. You're welcome to banter in here at any point in time. But, you know, a senior died after a nurses gave him another patient's medication. I used to work in a large ICFDD, and I was a trained medication administrator. And there was many times where I messed up, and sometimes that happens for a variety of reasons. I didn't follow protocol, or there was a lot of different competing things happening at the same time. And sometimes when you're working a double shift or you work the night before, mistakes happen. Now, did I show up to work to give somebody the wrong medication? Absolutely not. Felt horrible. But there's these environmental influences that we'll talk about throughout this afternoon. So this is just another example. Next slide, please, Eric. So, you know, again, the system response was staff failed to look beyond the room number to identify the patient. This is nursing 101, you know, again, going back to that blames, making sure that you're actually verifying, identify of the person you're giving the medication to. Well, like the examples I gave for myself, you know, there's some competing things going on when people are doing their jobs. So, and again, Goulet recommended that the direct care staff to follow best practices on administering medication and develop a complete nursing treatment plan for each patient. A lot of times what happens with the systems response is we add more training. I can go to training over and over and over and over again. And if you put me in a situation where there's competing environmental factors, the odds are pretty good I'm going to continue to make that mistake. Okay. Maybe not as often. Training's a great thing. I do a lot of training. I believe in good training and competencies, but you know, there's a lot of blame within our system sometimes. Next slide, please, Eric. Okay, this one always kind of blows me out of the water a little bit. Now, I'll just read this quick. So the hidden camera in this nursing home leads to charges against 17 employees that are charged with first-degree falsifying business records, first-degree endangering the welfare of an incompetent or physically person with a disability and willful violation of public health laws. Now, if you could, please, I'll pause for a minute here. Does anyone believe that all 17 of these nurses colluded to provide neglect to one patient in this nursing home? No, thanks, Diana. Yeah, I mean, you know, and then just another question, other than assuming that every single one of these workers was a criminal and intended to hurt the person, what are some other reasons that many workers falsified checks? What do you think? What was going on in the nursing home? No oversight? That might be a little blaming. Anybody else? Too many people. Courtney, excellent. Yeah, too many people to take care of at the same time. Understaffed, workforce shortage, overworked. Those are great responses. Lack of adequate training, maybe. It definitely could be. Significant amount of paperwork and less time to spend with, yeah, you know, it's the old paperwork conversation. I remember doing all the charting that I used to have to do, and that competed with actually spending time with people. Okay, that's real stuff. Required to do multiple things and couldn't get it all done. Yeah. Emergency with another person might have came up. Yeah, absolutely. Emergencies happen. Those are great responses. Thank you for those. So for the next slide, so the response, the system response, this behavior and lack of appropriate care is unacceptable, not be tolerated. made aware of the situation, we took action. Okay. The agency response that, what do you think that happened to those 17 workers? Anyone? Fired. Amanda, thank you. And fired. Yep, you're right. So they fired those workers because they couldn't tolerate that behavior. So blame, and then they're likely not able to work in the field again. You get a blemish in a healthcare facility and it ends up on your background check for neglect. You're going to end up working somewhere else like Menards or the gas station. It's sad. We lose really, really good people in our system because of quick system responses. Okay. I'm going to shift here. My piece is going to be done here in a minute, but we're going to watch a pretty heavy video that Eric's going to so eloquently hit the play button on, and then we'll talk about it for just a minute. Well, sorry you can't talk. I wish we were all in a room together, but here we are. You have chat. So Eric, you can hit the video unless you or Charles have something to add before we play it.
I was just going to add that the video, it's about 3 minutes or so, maybe a little less than that. And as Scott said, it's heavy. It does relate to a child death from a accidental prescription drug overdose. So just giving that forewarning of what it's about, in case you choose to step away. So I'll play the video and then we'll come back with reactions.
Step one, officer.
He lives behind concrete walls and steel bars. But Eric Kropp isn't sure if he's a criminal, a victim, or both. Are you a killer?
No.
In 2006, Eric Kropp was a pharmacist at a Cleveland hospital when 2-year-old cancer patient Emily Jerry was killed by the medical error of a pharmacy technician. She was given a chemotherapy drug mixed with a salt solution 23 times more concentrated than the normal dose.
His unit here.
But because Eric Kropp was the supervising pharmacist and should have caught the mistake, he was sent to jail. And that's where I found him, confused and struggling with regret. Do you think it was your fault?
In a way, sometimes. Because I've been called everything in the media and the way my coworkers have treated me. It's been hard.
But not as hard as it has been for Emily Jerry's mom.
Oh, she would go up and down the slide. Her swing was in the middle. It was still one of those child safety swings.
After Emily's death, Kelly Jerry pushed for laws in Ohio requiring new training and certification for pharmacy workers. And she was in the courtroom when the judge handed down Kropp's sentence. What kind of message do you hope is being sent by that conviction?
That patient safety needs to be first and foremost on everybody's list.
Is this going to make for fewer mistakes or more mistakes?
I think it's going to be the same amount of mistakes. It's just going to be covered up better.
Kropp says the mistake that killed Emily Jerry came on a day when he was overloaded and rushed. These are common complaints throughout the nation's medical system. And patient safety advocates warn that cases like this might actually make it harder to change the conditions where tragic errors are made.
People are going to be afraid to come forward and identify problems that they've been involved with because of fear for losing their license or, in this case, even having criminal charges brought against you.
Michael Cohen of the Institute for Safe Medication Practices was among experts sending letters to the judge, calling Kropp an easy target, saying the greater good is served by focusing on system issues that allow tragedies like this to happen. But in the court's eyes, Kropp had no excuse for missing the mistake that killed Emily Jerry. He's serving 6 months for involuntary manslaughter.
I mean, I have the stigma now. I'm a felon. I've hurt somebody. It's hard.
Terms of Kropp's probation will include speaking publicly, telling a story of caution to others in healthcare. He will never work as a pharmacist again. David Mattingly, CNN, Cleveland.
Okay. We showed a video. Just any reactions in the chat to the video? In particular, some of the language or system responses based on our discussion this afternoon. Yeah. Sad. Yeah, he'll never be able to work in the system again. Is there really one person at fault? I mean, what do you think? I mean, what was going on? You guys have been to pharmacies, pick up medications for yourself or others. I look at a line of like 10 pharmacists packing pills. Eek. That could be me, my friend, my coworker. Yeah. Harsh punishment. You know, yeah, when we look through this other lens, it is really harsh punishment. Because I don't think Eric Kropp showed up to work that day to pump it 23 times the dose into that particular solution for that kid. I'm just reading some of the chat. It was interesting that people said that new requirements would make it easier to cover up the mistakes and less likely to come forward. Yeah, and Eric Kropp even said it himself. They're going to be the same amount of mistakes. They're just going to come up with ways to cover it up better. Yeah, they do seem too overworked. I would never want to work as a pharmacist or whatever they do. And just a side note, a lot of the people I sit in line with when I do have to go are grumpy. Yeah, your customers aren't always the friendliest folks. I try to be a little bit over friendly when I'm there. Whether that helps or not, I don't know. So anyway, Eric or Charles, do you want anything to add? Thank you all for your great comments and tuning into this segment anyway. Eric, I'll turn it back to you.
Thanks, Scott.
Yep, thank you.
Yeah, and thanks for all the comments off this video. I think, like some of the first ones said, sad all around. Obviously, that overdosage and that young child being taken from the world is so tragic. And I think, as the comments were alluding to, that there's more to it, and what we'll get to, and what the old view really talks about, the new view talks about in our evolution is, okay, so that incident happens and Eric Kropp serves his sentence. He isn't working as a pharmacist again, and they were sharing, like, he'll go around educating people to slow down, to trying to tell people, using his situation as an example, which could maybe provide some benefit. You never know, but what we kind of get at there is, is that gonna get at anything? And as Michael Cohen, the person that studies medication errors and medication administration kind of nationwide, is just getting at, well, if someone needs to be sentenced, well, we think they're at fault. Okay, great. But if that's the only thing we do is that, and then try to, educate people, everything that people were adding in the chat, those things might just go unaddressed if we assume action's been taken by charging someone for something that they weren't even trying to do. So like Scott said, it starts to point us to questions about what else. So we are going to dig into some of that what else and continue to kind of look at how is this science, this safety science, what can it do? So a little bit about safety science. You can search safety science and find a lot of information. You can also search a longer kind of phrase or terminology called human factors and system safety. That's that's the longer version of safety science, but it's used in these kind of three big safety critical industries: aviation, nuclear power, and healthcare, as a approach to when critical incidents happen. Um, how do we respond, and then how do we learn and make adjustments based on what we learn? So it's an evidence-based approach that really seeks to understand that day-to-day typical normal work um, within any kind of field. It's looking at the performance of the workers, how and why incidents occur, uh, um, and kind of the organizational culture in complex systems. So, and the biggest thing that is sort of its, I'd say its headline of safety science is that it focuses on the systems improvements and working towards that rather than focusing on who is to blame, who needs to be held accountable, who screwed up. It kind of looks at from um, who is the issue. It tries to move away from who is the issue to what is the issue. So that's a little kind of quick hitter on safety science before we dig into this kind of um, shift from old view to new view. So we're going to cover kind of back in the 1970s about where the field of safety science started and how it's evolved into more of a newer view. So Sidney Dekker has done a lot of research. A lot of this research was done before his time on system safety, and so uh, as he started to get into the field of safety science research, he developed what he was seeing as a bad apple theory. And so, what he was kind of gathering from how people were thinking about incidents and how workers were performing and what solutions looked like is essentially that systems are perfect. They're kind of set up to not fail. Any kind of failures or accidents or mistakes that happen can be attributed to a human. And so, in general, um, and this is the kind of the premise of some of the old view. Failures are unexpected, and here's the tie to the bad apple theory, is that for systems to function at its highest level, and when we say system, it could be you could be thinking of our disability service system, you could be thinking about manufacturing or aviation, any kind of work, any kind of system of work. Could be Facebook, Apple, Netflix, Google, any of those big tech companies as well. All of those types of different types of systems. If you've got something going wrong, if you've got incidents happening, outcomes that are undesirable outcomes, that this theory assumes that if you find those bad apples, if you find those workers that aren't following the policy, aren't doing what's expected, if you remove those, then your system will be it'll correct. It'll be okay. You just got to find those apples and move from there. And then the last piece that this sort of approach takes is it's heavily weighted in outcome bias. So if someone's injured with any of our incidents, um, if money is lost, if you're talking more of in maybe the retail side of things or media side of things, the worse the outcome, as humans, we kind of tend to believe the worse the punishment should be. And so that kind of theory adopts sort of some of these tenets. A little bit more on that in this kind of sort of old view of thinking about a human's role, a human's mistake or error within an incident. We see our workers and their errors as the cause of the failure or a cause of the outcome. And when we look back then on an incident and we find, okay, what happened? Where did the worker not follow what we would say is maybe best practice or expected practice or a policy or a plan of care? Is that when we find where staff didn't follow what was expected, we tend to identify that and then move on to, well, how do we correct that? And so our learning, our discovery can sometimes end then with that identification of moving outside of um, not complying with policy or practice. And so our safety interventions then, if we only kind of learn this wasn't followed, this wasn't done, our safety interventions, our fixes, our solutions will tend to target those workers. We'll see what we kind of call in our work as quick fixes. These are sort of reactionary responses to an incident. And we see three common responses, very common responses to incidents, very common quick fixes. And this includes either more policy or changing policy immediately. It could mean more training. So a lot of times it maybe isn't always new training, but it's asking staff to retrain, take this training again. So we're kind of if someone doesn't follow what's in the training, we're assuming they don't know, they don't remember, and that the training will fix that. And in general, we might just see kind of some sort of maybe a new checklist, a new sort of reminder of the importance of this, some sort of documentation that needs to occur so that, we're trying to address the problem through fixing what the worker's been doing. And so ultimately, number 4 talks about assuming that people should do better with what they have. So when we put out reminders of like, if it's not documented, it didn't happen. If we're kind of using that slogan to try to motivate workers to update records or update plans of care, things like that, with documentation, that can often be really challenging for our staff because their reasons for not documenting usually isn't because they don't know it's important. There's other things happening. So it feels like this sort of do better with, do more with less is sort of the kind of feeling from the staff side of things. And ultimately that leads us in this old view framework to treat our workers as a problem to control. We need to kind of it kind of leads us to think that we need to fix our workers. We need to fix our staff to do better. Um, and so it's kind of limiting in how we're viewing our work and our systems and what's happening in the environment. It's not going beyond that. We're trying to kind of mold our workers to the environment, and that has some limitations. And so we're going to take a little bit of a example here of um, of what happens when we have a tough situation or a confusing situation for workers. So this this screenshot here of we got some blue underlined text, a list of um, different messages is comes from an incident that happened in 2018. Some of you maybe have started to read what's here and have maybe gathered this has something to do with Hawaii. And so to set the stage, there was an incident that occurred where an alert went out to the state of Hawaii that intercontinental ballistic missiles were coming to, I think it was Maui, were coming there and were that people should take shelter because missiles were on their way. So everyone received those notices to their phone, to TVs, to just a public alert that went out. So a very traumatic event. Like if some of you probably saw the news articles about it. I even know someone that was there. We've had people in our training that did have relatives or themselves there, and said, yeah, very traumatic. People were putting kids in sewers, hiding in bathtubs, finding any way they could to try to protect themselves from these missiles coming. Well, it turns out that the incident was a false alarm. So the staff, it was supposed to be a test of the alert message and not a message out to everyone. And so this is a screenshot of what the interface looked like for the worker that was tasked with putting out the test message. And so what they were at, or what they were supposed to press, was the starting at the bottom, the fourth one up, they were supposed to press drill dash PACOM CDW state only. So that's the alert to do the drill to test that that the alert message is going out. That would include language of like, this is just a test, this is a drill, to prepare for the future if this is needed. But what they pressed instead was just two above that. It doesn't have drill in the front, it just says PACOM CDW state only. So very similar message other than drill being at the beginning. The alarming part about this, and so it took 30 minutes to resend that message. They didn't notice it immediately after pressing it that they mistakenly pressed drill, or that the missiles were coming. And at this time in 2018, there was kind of high kind of conflict and disagreements with North Korea at the time, and so that was high on everyone's list, knowing that this is a possibility. What could occur here, and that amount of time is that 30 minutes that it took to resend the message is about the amount of time that it takes for missiles to come. So like people were in panic for that. Like 30, that's a long time to be in that panic and knowing that it could happen at any time. So if we look at this interface though, maybe some of you have already started to notice like, oh, I could see how this could happen. Because as this screenshot made its way around kind of tech circles and people that study incidents in this kind of similar approach, people were shocked that this hadn't happened sooner, because we see some interesting stuff on this list. The first thing I notice is that there's just a variety of types of alerts that are kind of all in different order. There's no great organization to it. There's some language about false alarm, amber alerts, missile alerts, tsunamis, high surf warning. So, a variety of messages. Some of the formatting, like the fourth one from the top, says a number one with a period, and then it says test message. So that almost makes it seem like it's a sort of a list, like the next 6 items underneath it are all maybe test messages. So someone could interpret that. So it's kind of like a drop down. There's a lot of different use of language. There's false alarm, there's test, there's drill, there's demo. And so, yeah, people were just really shocked that that in the safety science world that this didn't happen more often, because of how kind of confusing this interface is. And so that happened, and then the result, kind of using some of what we know about when incidents happen, the result of this incident was that the top image here says he was later fired by the Hawaii Emergency Management Agency. So their response was, essentially, how could you press the wrong button and not realize it? And so that person got fired. And then just about a year later, another false emergency alarm was set off in Hawaii. Not the exact same missiles are coming alert, but a similar thing where it was supposed to be a drill related to, I think it was something related to more of a weather related thing. And like the alarms that sound when there's like a test for severe weather warnings, like something like that was going off with which does, some of those events can be really destructive, can be also really traumatic. And so happened again. And so it just brings to light again, like if only thing we change in response to an event is removing what we think are bad apples, or we address it by maybe just a quick fix, we gather a surface level understanding that our workers did something wrong, and we correct it by firing or throwing a immediate reactionary solution to it, we might continue to see the same things happen. So this is a good example of that. And it leads us to kind of start to say, I think we need to look at systems learning differently than how we're responding in the old view. So we want to work towards, starts to work us towards the new view of safety. We want to point a, the science kind of points us to try to uncover more about features of our system that either are supporting the work or are not supporting the work. So it can look at both sides of things. When you're trying to be a little bit more proactive and not just reacting as incidents occur, you might trying to be studying where are things going well and why is that? And when incidents happen, we're going to talk about more of what we look at on the next slide, but we want to understand both sides of the story there. And how we gather more information about incidents occurring, and what was happening when staff didn't follow a policy or expected practice. The best thing we can do is engage those people working in our system. So that interface in Hawaii where the worker got fired, they certainly got blamed. I'm sure it was attributed to worker error, staff not paying attention, something like that. That person that selected that button and was working, we don't fully know that second story because immediately a reaction is kind of what we saw in the articles that Scott reviewed, is that staff get thrown under the bus. They get kind of told that they get talked about as as bad apples, as just workers that went rogue, workers that aren't doing their jobs. And those are the people that can give us the best information about, well, what about this was confusing? What was happening at the time of the incident? So we really want to work towards engaging those people. And if we respond in these ways that we've been talking about, of talking about our workers as failures, that they didn't do anything right, that they're, that essentially that they're replaceable, and that, they're bad workers. Sometimes it's looked at as they're criminals, that they should be charged. If that's the way we treat our staff, we're not going to get any kind of engagement from them about what happened and why. We're not going to get that further understanding, and that we're not going to be able to put ourselves in their shoes and learn from them very easily if that's how we're treating them. So we want to work towards that. We want to avoid blame in use of counterfactuals. So that language counterfactual might be some new language. So the definition of that is or some examples of that is when after an incident, and it's kind of using our, as we talk about being aware of our biases, it's a little bit about heard about hindsight bias, or people use the term like hindsight is 2020. So 2020, 2010 is a desirable, like, perfect, really good vision. Well, hindsight is 2020 is meaning when you look back at an incident, everything's a lot easier to see. You're not there in real time. You don't have that pressure of what was happening at the time of the incident. You have all the facts and information in front of you. And we oftentimes hear people kind of using counterfactuals when we're engaged in hindsight bias. When you hear people say, well, they should have done, they should have locked the meds up before they went and helped the person with their meal, or they should have turned the door alarms and door chimes on, so that then they would have known that the person left the home. If they would have turned that on, then this wouldn't have happened. They would have been notified. So we start to kind of look back and make assumptions about outcomes being different, decisions being different, based on what didn't happen. And that's problematic because that leads us down this path of assuming that the outcome would be different if the worker would have done something different. But there's a lot of different variables into why or kind of what a worker faces day to day, moment to moment within their direct support. And so we want to be aware of some of those things and look beyond that. Safety science really points us away from studying what didn't happen. So like saying like they should have done this, and it points us to studying what did happen and why. And so it really challenges us to pause and become a curious investigator. And Scott alluded to that language of second story. So we use in our safety science culture of safety work, we use kind of first story and a second story. And we need both of those stories. So our first story is something along the lines of where workers went out of went outside of policy or expected practice. So we do need to know essentially what should have happened. It's natural to start there and say, we expected staff to do this and that didn't happen. Now what we need to do is get, well, what's the why and how of that? And that's our second story. We want to be able to understand, why didn't they lock the med cabinet? Why didn't they turn the door chimes on? Why wasn't the wheelchair straps or wheelchair brake on for the person that uses the wheelchair? So we want to get to that second story and we want to engage that staff. And so as we think of that being sort of what we want to work towards, we start to see these five kind of these kind of are like if you compared and contrast the old view and new view, these are the evolution of our new view, our view of safety. So this new view approach starts to think of when we see failures, when we see mistakes that are happening with our frontline workers, that are happening to our staff, whether it's a case manager, assessor, direct support professional, any of those, if they're making mistakes or quote unquote failing to do their work, that's a sign that there's deeper trouble within our system. It's more than just the worker. So we were already charged right away that when incidents are happening to staff, to people, that there's more going on there. And so our learning then starts with the human error. So when we identify where that task or action wasn't done as expected, that's where we start to want to uncover more. And that leads us then to wanting to work towards our better understanding of what was happening so that we can get to better decisions around system design, better outcomes, things like that. When we really start to then adopt a value and the principle of recognizing that people and our workers are why our systems work. We couldn't have a disability services system in Minnesota, across the United States, without our frontline workers. And so instead of treating them as a problem to control, we're adopting it. We know they're doing the best, 99%, as Scott mentioned. Sometimes you do have some workers that are trying to intentionally abuse or harm a person. And we've got systems in place to identify those people, charge those people, and we do want to remove those bad apples. But when you've got workers that are motivated to keep people safe, to support them with informed choice and support them with making decisions about their life and living their best life, we want to be able to value that and learn from them. And so we then see in the new view, let's learn a little bit more, and then we start to see interventions, solutions, fixes that also try to target the environment and the systems of which those workers are in. So we move beyond those quick fixes to studying the problem and then developing solutions. So that's a little bit about that evolution transition from old view to new view as we think about safety and systems learning and improvements. So Scott covered some incident and system responses in the old view. We're going to start with a reminder of what does that look like when you've got an old view kind of response from your system, and what does a new view response look like? So back in 2014, Minnesota had its own high-profile child death, and so same kind of optics as some of those other ones, where county workers and those involved from a kind of human service, social service side of things were receiving scrutiny for not doing what was expected. They didn't do enough, is what the message coming out from many sources were saying, is that these social service workers, these child protection workers, aren't doing their job, is what a lot of the media articles were saying. And again, just like Emily Jerry, just the unthinkable and the worst when you've got children that are getting murdered, and we're losing them. So, an old view response coming from the governor of Minnesota called Polk County's handling of Eric's case a colossal failure, and said they should have followed through with the requirement to notify law enforcement of maltreatment reports. It's just inexcusably and immorally negligent. So that, I mean, when we've got outcomes where it's bad outcomes, it's unexpected, it's not what we would want. It can be kind of, the old view response can be common and typical, and it's true that the end result is not what we would want. But again, this is how we are talking about it, and to no surprise, I think Charles will cover a little bit about this. There was some really trying times for our service system after this that has led to improvements, but that also really just continued to spiral in that cycle that Scott talked about, where people didn't want to work in this field after how we talked about some of the workers that were involved with this incident. So to compare this to a new view response, this is an incident that happened in 2016 in Arizona, where 3 children were found murdered by a family member. And the optics of this one was the Department of Child Safety in Arizona had recent multiple contacts with the family about placement, about whether kids should be with the family, and then before anything was done, these 3 lives were lost. And this was the response from the director of child safety with the state of Arizona. So I'm going to read this. It's across 2 slides, and just read how, as when media reached out to him to respond to what's going on with your agency, what's going on with the state of Arizona, why aren't you protecting these children? Look what happened. Here's what his response was. It is a sad day as we reflect on the gruesome nature of what occurred. We grieve as a community, trying to understand why 3 innocent souls have been taken. We grieve as an organization, suffering the loss of children whom we knew. When a child is murdered, it's common to ask if something could have been done to prevent such a tragedy. At DCS, we ask ourselves those questions because we take the responsibility of protecting children very seriously. But our powers are limited. We cannot predict the future, and people can at times do awful things. We offer our deepest sympathies to the family and pray for the peace of the departed. I ask all of us to respect, support, and commend the dedicated men and women of DCS and law enforcement who do the unimaginable, who do when no one else can or will, who comfort the afflicted, protect the weak, and wipe the tears, who then go find a private place to shed their own. And in terms of media coverage and kind of continued reports about the scrutiny, there wasn't any of that. The story stopped that day with that response. So I think, or we think, this is a real powerful kind of message, especially if you're a frontline worker, you're a DCS worker that is doing your best in probably really challenging times. And it's not, you kind of see it in this person's message, is that it's not saying it's up that this director's okay, it happened. But you can also see he's deliberately not blaming those frontline workers as in his interview, and he's just taking it for what it is, of this is really tough on everyone. And what we do know, there is a reason he responded in this way, and it does relate to sort of our approach too, is that they were having lots of issues like this. This wasn't the first one of those. This was a kind of continued cycle, and so they started to use this, Arizona, started to use this same incident review model. So called it up here collaborative safety model because they were engaged with this organization. And so this is a news article on the left that is Greg McKay, who, another quote from him about like what they're doing to try to address their child welfare system is, we've implemented what we call a safety culture. We're not going to talk about people as failures as much as this is systemic and process failures that lead to outcomes that we would like to be different. That's had a huge impact, and our turnover rates are now in the mid 20s. So, as Arizona recognized the need to do something differently, they too engaged with implementing this sort of model, offering these sort of trainings to try to shift the mindset of to look beyond our workers and our frontline staff as kind of scapegoats and people to blame, but to look into our system and see how that's impacting things. So we said we would take a break right around the halfway point. So we'll work towards that. Is there any kind of, before we go to break, or as we go to break, any kind of questions or comments about what you've heard about the old view and new view of safety that anyone wants to add to the chat? Love to hear reactions. Like Diana said, I think Arizona response is well said. It really does. If you imagine yourself as a frontline worker, and maybe some of you have had incidents happen or fatalities happen, you certainly can feel the support there. But any other comments or thoughts about what you've learned so far? All right, we'll monitor the chat and give you some time during break. Let's take about a 5-minute break. We'll come back at 2:30. So this gives you time to get up, stretch your legs, use the bathroom, get a snack, and we'll start back at 2:30 or 2:31.
All right. We're going to go ahead and get started again. Hope you all had a good break. I'm going to kick things off with a question here in just a minute. Again, my name is Charles Young. I'm the Legislative Coordinator for Disability Services Division here. I've been one of the trainers since the beginning of the pilot in the disability services side back in 2019. We're going to talk a little bit now about our journey, how we got into safety science. Eric, Scott, they covered what safety science called the old view and the new view of system safety. Hopefully you saw that a lot of what we do using the old view led to blaming people, retraining, suspending, terminating them. And then oftentimes we considered our job done, and we assumed the system was safer after that. We should note that the old view did get us pretty far, so we don't want to discount some of the value to it. But safety science and the new view tells us that this approach, that old view approach, can be pretty short-sighted in some cases. To recognize this, the next question is, how do we incorporate safety science and the new view into our daily work? And so again, before I get into Minnesota's journey, I just have one question for you. If you're at this training, you're likely in a role where you're reviewing critical incidents or have some sort of responsibility for responding to incidents at your agency, whatever level you're in. So this is a well-informed, well-experienced group. And so I'm kind of interested to see what kind of answers we'll get here. But if you could change just one thing about our system, whether it's your workplace, whether it's state law, something DHS does, et cetera, in an effort to reduce critical incidents, what would that one change be? If you could just make one change. I'm going to give you a couple of minutes. I know some people are probably still coming back. To put it in, all answers are welcome here. This is just an exploratory question. It's the same question that we asked ourselves as we went into this project then too. So again, maybe I'll write it in chat. What's the one thing you would change in the system to reduce critical incidents? I'll make it think hard in the mid-afternoon. Hopefully everybody's got their caffeine. Just did want to call out Jenny's response that I think that the new model makes it less risky to do the frontline work. I'm not sure people in other fields really understand how you put yourself at risk working in helping professions. Yeah, thank you for that comment. That's something that many of our trainers with Collaborative Safety LLC have noted as they talk to other people working in safety science, that as they talk about human services, they're hearing from aviation, nuclear medicine, other areas that human services is pretty complicated. And yeah, our workers oftentimes take risks. So we've got some answers coming in. First thing, we've got expectations we change. We're expected to serve a certain number of people and keep up with all documentation and make no errors. But the people who identify these numbers aren't frontline workers and typically haven't been in a long time. We also have reduced the negative media coverage. There's so many things that can change, but that might be above all of us. Yeah. I'll give it just one more minute. I will note, again, I'm the Legislative Coordinator for Disability Services Division. We've seen, a lot of this reactionary response of the old view with the legislature. A lot of times it is the higher ups that are calling for, whether you want to call it punishment, of someone, whoever was in charge, or somebody needs to be held accountable. I think we all know what accountable means when that's asked for. Reduce caseloads. DHS should provide direction on caseload reduction. Oh, good. They're coming in. Thank you, everybody. Less paperwork hurdles to have to jump through. And just talking about the nuance within each case. Thank you very much. One of the things that we heard the most really from our committee, and we're going to talk about our steering committee, is I think a lot of people went into this again assuming that staff training and just trying to get some higher quality staff would also be one of the things that they'd change. Throughout the course of our project, we've been trying to look at exactly what are those systemic influences that are leading to critical incidents, because we want to try to see, well, if there is just one thing we can change here at DHS, what should it be? So going to the next slide, looking at just Minnesota's journey, how did we get to this approach? How did we find it? Eric talked a little bit already about the tragic case of Eric Dean back in 2013. After the death of Eric Dean, many of you might remember that some of you might have even been involved at one level or another, but the governor convened a task force on the protection of children. They were meant to advise the governor and the legislature on systemic and practice improvements in the child protection system at all levels of government within the state of Minnesota. The report is public for those of you that are interested. I think it came out in 2015. It had officially 93 recommendations from this group, but I think each recommendation had 2 or 3 sub-recommendations. So it really was about 300 different changes that this group recommended be made to our system to try to reduce these child protection, child death cases. One of the major concerns that came out of this case and what this steering committee, this advisory committee realized was that there was a whole lot of blame in the system. We've got issues with lead investigative agencies, maybe not always able to share information with different agencies, the state provider agencies then as well. And so one of the things that they noticed was that we just needed to get away from this culture of blame, which we've talked about now quite a bit. It's known now as the old view, and the results of that old view then too. So they noticed this culture of fear and defensive practices, and they wanted to move away from that. But it was really hard to identify an approach that would indeed do that. Luckily for us, I believe it was Eric or Scott also talked about Collaborative Safety LLC. This was a company that was created by 2 workers from Tennessee. One of them used to be a deputy commissioner or assistant commissioner out there of child welfare and disability services. They had started looking at some of these safety science approaches that were being used to reduce critical incidents in many of these other fields. And they had introduced their approach in the child protection system in a number of other states. Again, I always hate to do this, but I believe Wisconsin was ahead of us on this one. And so as the state of Minnesota was looking for another approach and trying to figure out, well, how can we look at cases in a different way so we can get away from this culture of blame? Wisconsin had a lot of success using this new approach created by Collaborative Safety, which, again, we're going to get into here in just a minute. So the Minnesota, our Child Safety and Permanency Division, they started using this approach, and state law was changed 2015, I believe, that required the state DHS to review every case of a child death or near fatality due to maltreatment. And this new approach that started to be used back in 2016. There was, I think, such positive feedback between the lead investigative agencies and the state regarding this approach and how it created a more collaborative environment. Made everybody realize that we really are on the same side. Lead investigative agencies, the state, provider agencies, advocates, we all have the same goal in mind. And this approach brought all of them together to talk about systemic issues. There was such great feedback on this that it was really one of our disability providers and lead agencies that asked whether or not this approach could be used in disability services to review critical incidents then as well. So we reached out and started working with Collaborative Safety LLC as well to try to adapt their model to disability services. So if you go to the next slide here, you'll see that the collaborative safety model is meant, again, and we've talked a little bit about this here today, to be based in human factors and system safety science as we've been calling it. Their approach integrates behavioral analysis, forensic interviewing, and trauma-informed science. And they really want to use the scientific method rather than a reactive method to support culture change. Next slide. So a couple of the goals that we created for us as we were adapting this model was, again, we wanted to move from that culture of blame to a culture of accountability. We wanted to focus on the system rather than the humans only. So we didn't want to just stop at the human error that many critical incidents reviews end up stopping at then as well. But we wanted to figure out what were those systemic issues that might have played a role to this critical incident then too. Safety science, and those of you that are already, maybe your interest is piqued in this approach, we do a 2-day training on an advanced practical training, then 2 on our model and on safety science. And you'll hear many times from us within that 2-day training that one of the things that safety science pushes us away from is applying quick fixes after a critical incident. And I think many of you can probably relate to that at your organization or at the state. There are state laws that have been created after just one incident that oftentimes don't necessarily apply to other incidents, but nevertheless they were there because of the reactionary nature that we as humans have after a critical incident wanting to take care of an incident. Rather than moving towards quick fixes, we wanted to pause and try to understand the underlying features, the underlying systemic issues before creating our quick fixes. And as I mentioned at the very beginning, sometimes those fixes that we're looking for, those systemic fixes, will require the legislature to make changes. But sometimes they're pretty easy. They can be done at an organization level. They can be done at the lead agency level. And they can be done at the state level then too. We've talked quite a bit about this already. We talk about it a whole lot more within our 2-day training, but we do try to look beyond that first story after a critical incident comes out where it sounds like a staff did something wrong, should be terminated. And we start asking that second story. Why did it make sense for that staff to do what they did? If it didn't make sense, they probably wouldn't have done it. And one of the other tenets that we really understand through our approach now more than ever is that if a staff is acting or reacting at one home or one site in one way, it's very likely that another staff somewhere else is going to do the exact same thing. That's exactly why that bad apple theory doesn't always work. It doesn't always make the system safer, because if these systemic issues keep forcing some of our staff to have the same reactions, well, then we've got to start asking about, well, what's going on with the tree rather than the apples? Next slide. So just a quick note here on just blame in general. And we apologize to all of you who are at the orientation rather than the advanced practical training. We know Brene Brown is such a role model out there, and we use a lot of her research as we're talking about the difference between blame and accountability. In an effort to hold ourselves and our system more accountable, we knew that we actually have to get away from blame, because again, a lot of our critical incident reviews stop once we find the right person, the right organization to blame. We needed to go beyond just that blame and again, take a look at those systemic issues. Brene Brown tells us that there is an inverse relationship between blame and accountability. Blame is just the release of fear, sometimes hostility and aggression. And a lot of times we just want to, again, we want someone to blame so we can just be done with the case, rather than looking at some of the hard changes that we might need to make to keep critical incidents from happening again in the future. For that reason, blame oftentimes shuts down the learning process. Again, we think the system is solved once we find the linchpin, the person that is responsible for a critical incident or whatever the bad issues that happen. So what we do know and what safety science tells us is that the people who are making the decisions, whether they're considered bad or mistakes, they're the ones with the best information about why they did what they did. And so we need to go to the source. We need to go to those people who made the decisions if we really want to understand why they made the decisions that they did. So again, those are some of the tenets behind this. On the next slide, talk a little bit more about just avoiding quick fixes to better understand issues. We know that, again, to make meaningful change and address real problems, we have to find those systemic issues that change, or systemic influences, and address those. There's probably a great example that we got from a provider after one of our 2-day trainings around just trying to move away from quick fixes to understanding these underlying features. It was after a 2-day advanced practical training that was actually introduced by our Collaborative Safety LLC partners, that a CEO of one of the provider organizations, a residential provider, came up and said, hey, I've got this home where we've got a revolving door where on the overnight staff. We've got an awake overnight. We have staff that keep falling asleep at night. And again, it's just this revolving door. And we have a one strikeout policy. So we hire somebody, they fall asleep, we fire them, we hire somebody else, they fall asleep, we fire them. And it wasn't until this training that I started asking myself, well, why is this an awake overnight if everybody feels so comfortable to sleep? Is there something else that we can do to help ensure that people stay awake? He was working with a very quiet home. Everybody slept, it seemed, in general at night. So there wasn't a whole lot for staff to do on the overnight, but yet they were required to stay awake, and they had a really hard time to do that. Staff sleeping is one of the types of critical incidents that we're looking at through this process. So we've got some more learning that we might touch on here today then too. So again, well, and we just want to note here, this is another good example where we're not necessarily saying you won't always have to stop retraining, suspending, or terminating staff. There are bad apples out there. But it is safety science and the new view that says we can't stop there. That can't be our final result. And ultimately, if we want to get more information from our staff that are making decisions, we have to make them comfortable to give them this information. So they can't always assume we're going to come down with our hammer and dole out punishment after bad things happen. So let's go to the next slide. I think that covers quick fixes. Last tenet, again, was really trying to move beyond those first stories to the second stories. There's no better example of the second story features than an iceberg. Usually, as long as some newspaper articles are or some critical incidents are, that critical incident or that newspaper article really only covers the top of an iceberg or the first story. But all of us who are in the field, all of us who have been in a critical incident, all of us who have had to make a decision, whether it was good or bad, in that case, know there was a lot more going on under the surface than just what happened. Sometimes we've got years of experience working with a specific individual that kind of led into some decision making. So we know, again, if we want to get information from staff on why they did what they did, we've got to dive beneath the surface level descriptions of incidents to better understand the sources of failure or success. Next slide. So again, as we kind of moved into this pilot, and we started talking about this in 2018, again, we wanted to know, would this approach, would these tenets work in disability services as we're looking at critical incidents? What we really hoped for some of these expected outcomes when we got started. There's some really good examples, even in the chat here today, when those of you got to read what Arizona said about after a critical incident, after unfortunate child death. Rather than not wanting to work in Arizona, I think we had two people in particular said, I want to work there. Even though critical incidents happen, when we support our staff, we know that they're going to be more engaged, morale is going to go up. And we've seen that through this approach in some of the other areas where it's been used in child protection agencies throughout the country, even within our own child safety and permanency area. So we were hoping to see that increased staff engagement and morale as well as we applied this. We wanted to see some improved staff retention for those organizations that were taking part in this. We wanted to see increased accountability. We wanted to move away from some of those responses that you saw, even from our own governor after Eric Dean's unfortunate death, and move towards more of Adam McKay's response there then too. Provider organizations, lead agencies, and state staff that participated in the steering committee, we also actually saw this move to a culture of safety as the next step in our person-centered evolution. And ultimately, we wanted to improve our services and see fewer critical incidents as we went ahead with this pilot. So going from there to the next slide. Just wanted to pause again. I'm hoping to go back to the chat and see anything else that was added. Up until a couple of years ago, I was in direct care in another state. Biggest frustration was my inability to impact decisions that were made above me. They had different priorities and not willing to hear my concerns. Yeah. That's something we often hear from our DSPs. And we're going to talk about how we're trying to get their voice even more so heard throughout this process. And one more vote for reduced caseloads. I think many of the one fix options that everybody offered here today were some more of those systemic issues and moving away from just issues with people. So I think that's great to see. You guys came prepped. That was good. So let's talk about our model here. This is something that we are working at the state level to introduce this pilot. So there are some things that we're able to do that maybe not every agency out there will be able to do themselves, but we've had a lot of provider agencies and lead agencies as well come to us trying to figure out how they might be able to apply this to their work then too. So we're going to give you the whole rundown of what we're doing, and we hope you might see some ways that you can apply this to your organization or some of the incident reviews that you're doing too. When we walked into the pilot, we wanted to look at, we had to look at really cases where DHS was the lead investigative agency for disability services. The one that stuck out the most, of course, were incidents that occurred in 245D licensed facilities. DHS is the lead investigative agency for any potential maltreatment that comes in a licensed facility. And so we wanted to look at our home and community-based service providers. So we're looking, we started by looking at residential and day service facilities. And when we first started in 2019, taking a look at our incidents, we also kind of wanted to look at some incidents that were oftentimes screened out. Really, I think as we were talking with our licensing area, they noted that we received a high volume of some of these types of incidents, but we're not able to always intercede depending on the circumstances. And so the ones that we chose to start looking at were medication errors, elopements, service terminations, staff sleeping, and wheelchair safety. We added service terminations about a year and a half, 2 years later, after we had such success reviewing medication errors, elopement, staff sleeping, and wheelchair safety here too. One of the other ones that's not really listed here, we started this pilot again back in 2018. That was before the pandemic. As soon as the pandemic hit, we did take a quick pause, but it was providers that came to us again and said, hey, there's a lot going on with COVID response. You should really start this process up again, and you should look at COVID incidents that are related to COVID. Everything was intertangled. We started trying to look at COVID-only cases, but of course, COVID-only incidents are not something that is necessarily reported to DHS, so we had a hard time. But COVID was definitely systemic influence in many of the cases that we were looking at. We're now in 8 counties. So if you're a provider agency that has a location in one of these counties, we are going by county of, well, residents rather than financial responsibility at the moment. The 8 counties are Blue Earth, Clay, Dakota, Hennepin, Homestead, Otter Tail, Polk, and St. Louis counties. So widespread of counties, we've got urban, we've got rural, outstate, and metro counties in here then as well. And that gave us a good idea of the type of incidents and the type of differences between these areas then too. We mentioned this was a pilot. When we went into this again, a lot of the reason we were going into it was to figure out if this is an approach that would work for disability services. All of a sudden, though, as we started looking at these cases, we were getting a lot of data, just as you're supposed to when you're applying a safety science model. And we needed somebody, we needed an organization, a third party that could really take a look at our data and review it to tell us whether or not there's any systemic influences that are sticking out that we needed to take care of and what those systemic fixes might be then too down the road. I believe we have some people here today from our regional quality councils. They started reviewing our data, I think it's about 2 years ago now. And so they've been looking at the data that's coming out of the project and reviewing whether or not the state should consider any systemic changes down the road then too. Again, whether those are policy changes or whether they might need to rise to legislative changes then too. So that has been a great collaboration. Because for those of you maybe unfamiliar, regional quality councils are comprised of advocates, some people receiving services, lead agency staff, state staff, and provider staff then as well. So a great assortment with a lot of diverse perspectives on our system then too. The last couple of years, we have tried to turn this pilot from a pilot into a project or an initiative. And this last year, 2023, we were finally successful. The Minnesota legislature did see fit to canonize the language and the work that we're doing around disability service incidents, giving us authority to continue to look at these types of incidents, but also to make sure that the people that are participating in our process have protections when they're giving us information about their perspective. So because of this language that has changed, we are going to be able to broaden our scope to other counties, to other lead agencies then as well, and potentially even new incidents down the road then too. Anyone that's interested in the language, feel free to reach out and we can pass that on. It did just become effective recently, and so we are still kind of working through that, but excited that this is no longer just a pilot, but now an initiative. All right, next slide. So we've been talking for almost 2 hours about critical incidents. We talked a little bit about this already, though, at one point, but when we at DHS are talking about critical incidents, we just, again, want to give you an idea of what we're talking about here as we're moving forward. We get our information on critical incidents from a number of different ways. We've got our Behavioral Intervention Report Form, or BIRF. We've got the adult maltreatment reports coming in through MARC, child maltreatment reports, serious injury reports, reports of death. There are critical incidents that need to be reported by our children's residential facilities, CRFs. And then another type of critical incident, again, that was added later on were the 245D service terminations. For this project, we are just getting our critical incidents data right now from 245D service terminations, BIRFs, and adult maltreatment reports. And one of the reasons why we wanted to show you this Venn diagram then too is we probably already have a pretty good idea that the system is pretty complicated. I think just this critical incident reporting mechanism or clockwork here kind of shows you a little bit more about that, because there are some incidents out there that are reported in more than one way, or have to be reported in more than one way. And that's just one of the complications that we have going on with our system then right now. So one of the things that we oftentimes have to do as we are reviewing cases that are coming in is we just have to rectify which cases might be the same ones, even though they came in via different reporting mechanisms then too. So this is something our providers, lead agency staff, lead investigative agencies, and DHS licensing is also kind of working to parse through this complicated system. All right, next slide. So as we're going into the incident, now you know where our incidents are coming from, what we're talking about when we're talking about critical incidents. You at your level, depending on where you're coming from, might have a different idea of critical incident, and definitely this approach could be used for things other than the critical incidents that we're talking about here. But just as we're going into reviewing our incidents, just a quick word again about our incident review approach. Some of this might sound pretty familiar from some of the positive behavior support or positive support tenets. Some of it's coming from person-centered planning and thinking then too. But we go into each one of these with the understanding that all behavior makes sense. That's the staff behavior, that's the people receiving services behavior, lead agency, state staff. It all makes sense from their perspective, and they did it for a reason. Nobody makes an error in real time, right? If it's an error, and if you do something on purpose, if you make the wrong choice on purpose, well, that's not an error. That was on purpose. Sometimes it's malicious. So for us, we're going in again, assuming with those good intentions that nobody came to work to do a bad job. Nobody came to work to try to make an error. And so all of it makes sense, and we've got to figure out why it made sense under context. We also have to be aware of our own biases, the hindsight bias, outcome and severity bias, which we've touched on here a little bit then too. We have an entire critical incident report in front of us, sometimes an entire case history in front of us then too, as we're reviewing critical incidents. And so things make a little bit more sense after an incident than when you're really living in real time during one. Our goal is always to understand the local rationality of the staff, who again were making the decisions, whether it was the decision to set up more med cups than they should have on the day of, or making the decision to terminate a person's tenancy. We want to understand their focus of attention, how they might have prioritized work, their knowledge about a situation, a person, a plan, and potentially the goal conflicts that they're working with then too. This allows us to study those influences or decisions on the context in which they were made. And it also provides a window to understanding how the operational system influences workers. One of the things that we have, that I think we're all prone to do too, though, is kind of make some jumps from, hey, because DWS gave us this staffing level, this is why we're here today. Because MinChoices assessed this is why we've got this staffing level. And we always want to understand the rungs in between. How do we get from the 6790, for those of you who have to fill them out, list this, how did that get us to where we are here today, and kind of what were some of the decisions behind how the 6790 was agreed to. So let's go to the next slide where we get really into our approach. Once we select a case, whether it's one of those incident categories there, our next job is to try to debrief, again, the staff that were involved in the situation. For our project, this debriefing is voluntary, and it's typically one-to-one. So if we choose a critical incident that from your organization, if you're a provider, if we select an incident that perhaps you were case managing, or perhaps somebody that you're working with as an advocate, or you're a self-advocate, we're typically only talking to the staff that made the decision. But again, this is a very voluntary right now process for us. Again, our purpose is to learn about local rationality, to understand why it made sense to do what everybody did at the time, and also just understanding that it always did. And before we go out, we try to identify, well, what do we really want to learn about a case? We want to typically choose a learning point where a person's work went outside of policy or expected practice. Sometimes where people are working in the gray, where there is no policy, there is no practice, what informed their decisions from there. And so we identify those learning points before we usually go out for our debriefing. And again, we're usually trying to meet with just the staff involved. So if you are an administrator at a provider agency, and we are going to want to talk with your staff one-on-one. There have been times, of course, that some staff said I'd rather have somebody else there with me, and we can work with that as well. But we find, of course, that we get the best information from staff when we're able to do it one-on-one with them. I should also note that as far as who's doing the debriefing, on our side, it can be some of our disability services staff. But we're fortunate to be working with a number of lead agency staff then as well, and they come from a wide range of backgrounds. Everybody is volunteering at this point, but we've got child protection workers, adult protection workers, case managers, and supervisors of some of those units that all work with us as safety analysts who might be the ones making contact with a provider organization or even a lead agency, depending on the type of incident that we're taking a look at. Next slide. So on the last slide, we use the term local rationality, and this is a huge tenet of safety sciences, trying to understand the why behind someone's action, why it made sense to do what they did, and to really support, trying to support the staff and trying to tell us why it made sense to do what they did then too. When we're going out, we are specifically, again, and we mentioned this on the last slide, we're trying to capture their attentional dynamics. What was their focus of attention? Were there environmental clues? Were there red flags or little yellow flags, as we hear from a lot of staff then as well, in hindsight? What were their strategic factors? Were there some goal conflicts involved here or competing contingencies? A good one that we oftentimes run into is we know a lot of our residential staff have many different goals. Providing supervision to the people that they serve is usually first and foremost, but it's not the only one. Oftentimes they're still in charge of cooking, they're in charge of cleaning, and many times staff have to prioritize whether or not they're going to provide supervision or fulfill some of these other duties at the time. We see a lot of elopements, for instance, when staff are cleaning bathrooms. happens in movies and it happens at our residential facilities then too. If someone's going to try to run away, they look for those most opportune opportunities, and it's typically when staff have those goal conflicts that they're working through. We are also looking for those knowledge factors. Did the staff know the policies? Did they know the practice? Did they know the person's plan? And did they apply that knowledge? And if they didn't, why? Why did they not apply that when they knew it? And again, what we oftentimes find so far, and you're going to see a little bit more of that here too with the results, is that staff know the plan, they know the policy, they know what they should have done in a case, if I can go ahead and use a counterfactual. But they did something else for some other reason, and those are the reasons that we're trying to uncover when we go out for these debriefings. Next slide. The next goal for us is to take all that information to what's known as a systems mapping. For those of you that are interested or in this process, it's, the mapping type that we're using is known as an ACCIMAP, an ACCIMAP. It was developed really to look at those systemic issues that influence critical incidents, and it wasn't developed for human services, but our contractors, and we have found that the ACCIMAP works really well for trying to identify systemic influences and then catalog them as we conduct one of our mappings. If you're going to try to uncover systemic influences to a critical incident, it is really important at this point to have all layers of the system, all levels of the system represented within a systems mapping. So at each of our maps, and we have a mapping team for each of our different regions, we have representatives from providers, from lead agencies, and from state staff. Then who can all provide insight into some of those systemic influences that might contribute to a critical incident that we're looking at. The idea behind, oh, yeah, thank you, Eric. I spelled it real fast, but this is a tool that I think we've heard some providers and lead agencies have gone and used them too. And we're going to show you an example of an ACCIMAP in a few slides here. The beauty of the ACCIMAP and systems mapping is to allow for the exploration of any issues from the systemic perspective. We've got all layers of the system represented on here, and we expect representatives from the system to help try to fill in all of the gaps as we work our way up. So a lot of times we like to say mapping is where the magic happens. That is because we've got the whole system represented there, and there's an aha moment, I think, in every single mapping where we find that maybe different representatives from the system weren't looking at a systemic influence quite the same way. And from a safety science perspective, that's where some of the biggest insights can come, is when we find that not everybody had the same understanding of some influence, such as min choices, such as 6790s, such as state statute, and so the list goes on from there. Next slide. Here we go. So this is probably pretty small on your screen. It's pretty small on mine. In fact, I'm going to move it to a bigger screen so I can hopefully see it too. I think on WebEx you can zoom in, if I'm not mistaken. But this is an example of an ACCIMAP. Hopefully you can see at the very bottom level of this ACCIMAP, we list all of the conditions, processes, and actor activities. So this is really looking at why staff might have done what they did. In the very middle, I think it's an orange. I'm slightly colorblind. Here you have the learning point. Thank you. Yes, you can see our learning point for this case. This was staff administered incorrect medication to a person. So obviously this was a case where we were looking at a med error, and the learning point was pretty basic. A lot of times it is. It's where staff went out of expected practice and they administered the incorrect medication to a person. You can see a number of those influences at the actor level, at the person level then. So all meds were passed at the same time. Staff was distracted because the radio was on. There were issues with the mother. Blood checks were having to be done. Staff felt pressure to pass meds. Someone was late in returning home. Staff were worried about adverse effects of medical condition via med time window. So a lot going on at that person level, and you can see these competing contingencies come out. Again, under a typical incident model, that's where a lot of critical incidents would stop. For us, we then want to go look, though, however, higher. We want to check out the other levels of the system, and so we've got the provider factors listed next. And then county and regional factors, external factors, and government and regulatory bodies. So at the provider factor level, you can see that, well, we've got issues around the staff schedule. We also see that it was common practice at this home to pass meds at the same time. We can also see what that staff ratio was. We had a 1-to-4 ratio at that time. And we also have an influence here of just the provider med protocol. And you can see all of the influences that led to each one of these then too. So the staff schedule, the 1-to-4 ratio, that all leads to the 6790, the beloved form 6790, where we note what the staffing level will be for each person. MinChoices makes it onto just about every one of our maps then too, because it informs many different responsibilities that are given to the provider. And moving up, you can see some of the external factors are notes from doctors. On this external factor, we oftentimes also see other things like guardian issues. We can see things like neighbors, depending on the case. And then at the very top, we get our government and regulatory bodies, and DWRS 245D, the person's nursing license, all are listed here as those government and regulatory bodies. Just because an influence makes it onto the map doesn't mean that it had a definitive role in a critical incident. But these types of maps are very valuable to us because we can see some of these recurring influences in each of these cases. Again, MinChoice is 6790. Just because they're on the map doesn't mean that they were definitive influences, but they ultimately determine how a provider and oftentimes then how the staff that is working for the provider should be behaving in a situation. Our goal with this map then is to try to figure out again why staff did what they did and what those influences were from there. After we're done mapping, on the next slide, we then turn that map into a narrative, really the second story behind the case. So the narrative creates a detailed context of the map. It explains how those influences played a specific role and how they influenced each other. Sometimes influences can influence each other. They don't just go one way. And ultimately, it puts that map into the narrative form so that way we can go ahead and score each case for systemic influences. Next slide talks more about that systems analysis that's done on each case. We score every single one of our narratives for systemic influences, which we're also going to show you in just a minute. This is another part of our process that might be useful to some of you out there. The analysis identifies and captures those systemic influences and hopefully explains the complex nature of the work and many factors that influence the trajectory of care. It's this data, this scoring that we're passing on to the Regional Quality Council so they can see how definitive each influence was within a critical incident and then identify, well, which influences do they want to tackle and look for systemic fixes for them too. Next slide. Oh, still there, Eric? Looks like we might be still stuck on systems analysis. Oh, there we go. Oh, still there, Eric? I think there we go. Yes, perfect. Thank you. I might be the one glitched. All of our state computers needed updates today, and so all of us are a little bit slower than normal. Eric and myself are both getting new computers. I'm sure everybody's excited to hear that. After we've used our last ones, I think I'm on 6 years. I don't want to speak for Eric then as well, but thank you. This next slide is really kind of the payoff. So what have we seen? What have we seen through this approach? Well, since 2019, we've used this approach to fully review 71 incidents. And I'm going to talk about the systemic influences that we're seeing. But again, going into this project, I think a lot of our steering committee assumed that, well, staff knowledge and training would probably be the #1 thing that we would see that need to be addressed. Instead, what we've seen in our top 3 influences when we've looked at these cases is issues with prescribed practices. So that's going to be explained on the next slide, but that's when policy or work expectations are absent, conflicting, or not clear. The next top influence has been demand resource mismatch. A lot of times this is where we're seeing issues with workforce shortages coming in, where the resources available to meet the needs just aren't enough or sufficient in a case. And then the last one is cognition. That's not full when staff maybe not don't fully understand a situation due to focusing on beliefs or past experiences, or focusing on one way to do things when there are other options. From there, you can see some of the other issues. We've got procedural drift, production efficiency pressure, service availability. It's maybe no surprise to many of you out in the field, but we've seen a lot of service terminations that have been given to people, not because the provider was trying to terminate their tenancy, but because they were trying to help them access other services that can only be accessed when danger of losing placement is present. But oftentimes we're also seeing other services that just aren't available, whether it's in rural or urban settings then too, that were meant to support a person. And unfortunately, providers felt they didn't have the support from other services and had to terminate services. We've got teamwork and coordinating activities. And then finally, the one that we heard the most from our steering committee that we thought was going to come up the most was that just that knowledge gap from staff. You can see here it is not one of the major players so far in the cases that we've taken a look at here. The next few slides describe each of these systemic influences, and you should all have these now. We're not telling you to go out and start looking at your cases for all of your critical incidents for these systemic issues, but we want you to be aware of what we're looking for. And if you're out in the field and you're dealing with a critical incident and you're trying to figure out how to handle a critical incident afterwards, we think it's important to ask some of these questions. Am I dealing with a knowledge issue, or is this really prescribed practice and requires a systemic fix? So we talked about prescribed practice, demand resource mismatch, and cognition. The other big one that we saw was procedural drift, and that's when staff change how they do work because of challenges, coworker suggestions, or because the new way was successful. Safety science actually tells us so procedural drift is really shortcuts, staff taking shortcuts. And safety science tells us that much progress was made in human history because people found shortcuts. So we don't always want to discount that shortcuts are bad, but oftentimes, sometimes when we see some of these shortcuts, we also see mistakes or errors that happen. And I'm using quotes again here to describe those. Next slide. And I think, Eric, is this where I'm handing off to you?
I can take it the rest of the way.
Perfect.
Charles.
All right. Yeah, thanks everybody.
So then the last little bit we have is sharing what we've kind of learned so far from these incident reviews. So Charles left off sharing those. Well, I'll just go back a couple slides. So these systemic themes that we had, and so you see here this graphic has 71 incidents that were reviewed. So those regional quality councils playing that role of helping us look at the data and develop some considerations for recommendations for systems change. There's 4 regional quality councils in Minnesota, and in calendar year 2022, so last year, 3 of the 4 councils were looking at data. And the first kind of group of incident types that they were looking at was related to those supervision related incidents. So person leaves a home or work kind of unexpectedly, and staff maybe didn't see them. So that could be an incident that those were a type of incident that we were looking at. Or staff knew that the person left, saw him go out the front door, but they were the only staff working, and there are other people in the home, and so they didn't follow protocol that said follow staff. They or follow the person. They stayed home. So we were looking at incidents with related to that supervision, and then just a mention of this. regional quality councils, then we're looking at, okay, out of each of these, we had examples under some of these systemic themes where we were looking at, okay, out of these 8 supervision related incidents, we had prescribed practice coming up. And so that's just a little kind of context of like what types of incidents were these councils looking at in 2022, and what were we learning about? What issues or problems were coming up related to these incidents that we learned in the human factors debriefing, the mapping, and then related to the scoring. So a couple high level kind of issues surfacing from the data review with the regional quality councils was that 245D licensed providers. So as we mentioned, all of our incident reviews have been so far with this model have been with 245D licensed providers. So that's the call out there. We are seeing challenges providing person-centered supports when serving multiple people, kind of living and working in the same settings. So this could be examples of like these multiple people living together having differing needs, and staff trying to balance that and working through that. We had instances of maybe balancing many duties or tasks. So you've got multiple people that have differing needs, but you also have then varied tasks that might be direct support related in the moment supporting a person, but also like prep work for meals or cleaning or other things that are kind of expected practice that can be challenging to manage. And so kind of layered with this first issue with providing those person-centered supports and being in tune with that is that both case managers and providers having challenges then supporting what's called dignity of risk and balancing important 2 and 4. So that's a lot of the prescribed practice definition that we look at here at the top of the screen. When policy or work expectations are, there's a few different sort of clarifiers: are absent, are conflicting, are not clear, or does not support the work. So when we have this issue coming up of balancing important 2 and 4, health, safety, and well-being, dignity of risk, those are very real conflicts. Were very real examples of prescribed practice happening where in these incidents of supervision where staff are having, are challenged with, do I follow this policy to follow, or do I follow this policy to support someone that's at home? Do I, how am I working through some of that with, if we're out at the zoo or we're out at the state fair? Both of those were incidents that we looked at where people are out, doing stuff they enjoy, wanting to experience parts of the state fair, and it can be really challenging to, or it can be common to like lose where is someone. Like if some one person slows down and you get caught in the wave of people going down on a busy, almost every day is busy at the state fair, and it can be really hard to manage that. And an old view type of reaction is, well, why would you take them to the state fair? Well, they wanted to go. So you get into this space where there's a conflict here between, stuff looking risky, but also honoring people's choice and right to do, to experience things that they want to experience and do. And, certainly providers are working at, prevention plans and contingencies on if this happens, what do we do? But there's a lot to kind of balance and think through, and providers and staff are doing their best. So these are some high level examples of some of the issues that were surfacing in this first cycle of review in 2022. And so from this, so we start with kind of looking at it's qualitative data. So as Charles kind of walked through, we've got that map that we turned into a narrative, and then we score it to kind of quantify the the themes, the number of times these specific 13 systemic themes come up, we also then look at the qualitative data of like, well, what specifically was happening related to all of these examples of prescribed practice. And so that's just one example, like we were going through each of those and kind of looking at those related to the supervision. And through that discussion, the regional quality councils came up with, we've got here recommendations, another kind of language we sometimes use as well as considerations for recommendations. So what we mean there is the councils are putting these forward to DHS to consider. Here are some things that we think could help. And I'll touch on each of these, but I wanted to add that with each of these considerations or recommendations, each council said, well, before actually making this change, before jumping to this solution, this recommendation that we do think will help, they kind of cautioned and recommended with it that before acting upon this, we think there should be more engagement to the people that this would impact, whether it's people who receive services or the staff that would be expected to do something different, to kind of gauge is this accurate? Is this kind of generalizable throughout the whole state? Because these 4 recommendations were coming from, across 3 different regions. So we talked about the 8 counties. These recommendations were coming out of one region being kind of metro area with Hennepin and Dakota incidents, another coming from the St. Louis region, the north, and then kind of a little bit south of the metro, kind of a little bit east with Olmsted and Blue Earth. And so the caution there of and kind of wanting to make sure and before acting upon any of these is just to be able to see what else is happening, see if this makes sense in other areas. And so just wanted to add that as we consider recommendations, I think that made a lot of sense coming from the regional quality councils, and it aligns well with the new view approach of like, let's study it and let's get it right. Let's engage some of the people who do this work a little further to explore this. So a little bit on some of these recommendations. The first one there, so looking at developing some guidance to support both case managers and providers in having discussions and exploring the use of assistive technology with people. So that was coming up as we talked through related to kind of supervision and supporting people to be independent. Some of the reasons, a lot of times when people are leaving homes and leaving work, it does relate to something maybe not going as desired for the person receiving services. Sometimes that's they're wanting to get out, they're wanting to change things. And so as we talk about that and talk about how the impact of workforce shortage and things like that, and looking at sort of what's happening with what's out there about assistive technology. There's been more that's been kind of shared from DHS and DSD recently within the last year, 1 to 2 years about this, but just wanting to see a little bit more guidance around that. And so that was one consideration put forward, and it aligned well. We found out, the councils found out, and some of my role in leading this effort is that the Disability Services Division is in progress of creating a what's called a supplemental guidance page to the online site that's used to support some of our policy work, the community-based services manual, or for short, it's called CBSM. So that supplemental guidance page is being worked on to support not just assistive technology discussions, but support technology and service planning. And so this work group from the Regional Quality Council was able to put this forward and then also review a draft of that guidance page that will be coming out soon. Second recommendation related to a barrier kind of with sort of annual meetings that people have, where o- of a feeling of overwhelmed, being overwhelmed with the amount of paperwork in those support planning meetings. So, and that just kind of contributing to, um, and being an influence to, to people's quality of life and to, better serve them. And so thinking through, well, how does that, what can we do about that? What kind of comes out of that? And what they put forward was looking at ways to reduce and consolidate some of that paperwork. So knowing that those meetings can go very quickly, that there's a lot kind of to discuss, and that can be a lot of pressure for people to come up with answers to a lot of the big questions that are asked. And so trying to find ways to do that. This included some language in the recommendation about options to sign paperwork electronically or outside of the meeting. And so an update kind of on this recommendation would be, or is that we did learn and confirm and share with the, the Regional Quality Council and also the share out, because not everyone knows the same type of information about the process with paperwork. So we found out that there isn't any state policy or statute that prohibits electronic signatures. There isn't anything that says it must be used, and it's good that there's options. Like some counties are utilizing electronic and or paper signatures. I don't know of anyone that's fully electronic. So it makes sense that some people maybe want to sign things in person and by hand. Others would rather do it electronically. And so we found that there isn't any restrictions with that. But we also found that as far as we know, there's no current kind of efforts on reducing and consolidating the paperwork. We learned that a lot of there's multiple sources for that paperwork that is needed within a support planning meeting. Within disability services and kind of people that are on waiver services, there's one or two forms required from DHS. Other forms certainly might be influenced by state or federal statutes, but counties might have their own forms. Other agencies other than DHS, depending on the services that people are receiving, might have forms. Providers might have some of their own, and so it's still a goal and kind of a recommendation on how to reduce and consolidate. But we kind of learned in uncovering more about what that could look like is that there could be maybe a larger effort or more collaboration needed than just what's in the scope of Disability Services Division related to that recommendation. Just the last two recommendations that we'll go through. One barrier that was acknowledged in wanting to better serve people and people providers providing supports that are person centered and supportive of people in their choice and in their life. One thing that came up was that providers are seeing a gap in how they're reimbursed or compensated to develop some of those knowledge and skills to be person centered. So certainly there's been a lot of kind of training and information put out from DHS about the use of person centered thinking, the use of other person centered practices and positive supports. But in general, just kind of the notion and some of the language that the Regional Quality Council used is that the system's has kind of essentially made supporting people using person-centered practices, quote unquote, an unfunded mandate. So it being an expectation and that beyond the training that gets put out, that there can be limited resources for gaining that knowledge and skills. And so that resulted in a recommendation of number 3 of wanting that disability waiver rate system or DWRS to be adjusted to maybe include like a line item within the budgets that could be resources for person-centered positive supports, and that could be a way to support providers to get that knowledge, skills, and access to um, some of some of those resources, training, and information that they need to do that. So that was kind of shared internally within, fiscal policy, that rates area, and something that was kind of added to the list of DSD is currently working on some of the DWRS cost reporting process, and um, hopes to kind of continue measuring some of this gap and working towards looking at how to address this recommendation and move forward with that. And then a last kind of thing that came out of the RQCs was the recognition of, or the barrier that was kind of noticed, was that providers are often stuck in these challenging situations, like some of the examples related to supervising someone that leaves unexpectedly, um, where they might be in need of some sort of support, and might not always have the internal expertise and or capacity to address some of these challenging situations. And so, in light of that, kind of thinking about, well, we're seeing that's an issue where kind of in the moment support, real time support, is not there. If some organizations really try to work upstream and address some of those challenges or issues in the moment, but sometimes don't have the support to do that. And so this recommendation looks at wanting to create some sort of regional support model. That's a broad kind of term, but something that kind of breaks our state into regions and has some staff built into supporting 245D providers when they experiencing some of these situations. So this could be something like what we're talking about with like utilizing person-centered positive support. So maybe it's the situation where this person continues to leave the home, and they've done their best to access different services to figure out, why do they keep doing this? What do we need to change in our approach to better supporting this person? And this could give them whether it's, they don't have, the RQC didn't have this all spelled out in exact, like, this is exactly how it needs to happen, but more of a general notes on, like, could there be a phone line or an email line that could provide some of this interaction, planning, advice, so that they could explore some different options and get some support in that way. One example given for this would be, many of you maybe are aware that the Disability Services Division has a team called the Regional Resource Specialists. So these are some state staff it is a regional support model focused on, primarily providing support with lead agencies and in their work with both case management and assessment, and supporting people, working with providers and support teams. And so the RQC talked about, like, if there was maybe a similar model like that could be available for providers, that structure, or from this RQC, that approach with regional resource specialists was acknowledged as one that seemed to function pretty well for lead agencies. Could something like that be replicated for providers? So latest status on that is just Disability Services Division kind of exploring what that could look like, on in general, how to better support providers, and recognizing, like, that's a gap within the Disability Services Division. Certainly licensing, 245D licensing, another area of DHS supports providers in having licensing standards and processes with, sometimes related to incidents and follow-up and things like that, but wouldn't necessarily be termed as something that would be, upstream in the moment support. And so DSD is kind of exploring and looking at how can we do some of this? What can we do? Some of that is looking like it would likely require some legislative change, a proposal to achieve some of that, because we'd be looking at additional funding. but is something that is being explored. So this is new information. You know, if some of you have attended previous orientations, this is the first time that we've been able to incorporate some of this analysis. What's coming out of some of this work? What are we learning? And so in the future, so regional quality councils are currently reviewing now mostly medication air data and some of the 245D service termination suspensions data. So we offer this training every 6 months. And so next spring, hopefully the next time we deliver this, there's all of our snow has melted. Not to wish away winter for people that love winter, but we deliver this every 6 months or so, and so we'll look to if we have new recommendations that are coming forward. We'll continue to share that out in these trainings. Also, we'll have yeah, I just tuned up my snowblower last weekend, so I'm ready to go. That's what my wife told me is, why are you doing this right now? It's 90 degrees. I'm like, well, I don't know. It just felt like a good time to do it. But looking forward to sharing out more about our what we're finding and what's happening. And so Charles mentioned the new legislative language, the new statute that we have. So that also includes an annual public report. And so that's something that we will share on our website. I'm going to put our website into the chat. It's going to be going through an update. This website will include similar but hopefully better information. It will also have a tab that is related to the public report. And so this will have more information. This report will describe some of these details, some of what you're seeing right now, but have some information. And so that's another way we'll communicate the findings, you know, of our model and our process. So just making you aware of that. As a sort of wrap up, we've got a little bit left to just kind of consider transitioning all of us into, well, how do we utilize some of the safety science in our work? Like maybe some of you saw some connections with the old view and new view and maybe recognized like, oh, that is a kind of a human default to blame. And we do fall into this trap of where our biases really lead us to maybe oversimplified approaches to how we respond to an incident and how we try to fix. And so maybe you already have some ideas, but we wanted to call out a few kind of things to consider when looking back, especially on incidents. But when we use that term incident, we gave a lot of really specific examples of critical incidents, things reported to DHS in that kind of Venn diagram and how we're using it at DHS. But I want to remind us all that our definition of incident can go really broad. We referenced aviation, like an incident for aviation could be a plane crash, it could be an engine malfunctioning. It doesn't always have to be like the ultimate worst thing happening, outcome happening. It can be anything where we have an undesirable outcome or work didn't happen as expected. And so this can be applied, you know, at a case manager. It can be related to some of the support planning meetings or policies related to that, or expectations for interacting with people. A mid-choices assessment getting done in the time that we would expect. A provider, you know, we gave a lot of different examples of provider examples, but this can be applied really in any kind of field because it's an approach to try to study, learn, and improve. So a few other tips that we wanted to give as we think about applying this to our work. So these are some good sort of, you could call them ground rules or expected practice for kind of meetings. We use some of this within our those mapping meetings that we talk about where we have those boxes and arrows. But these can really be applied when you explore an incident and you think about how a team is discussing and talking about what happened. So we really adopt the notion of all perspectives are valid. We get into this, we want to hear differing opinions. We want to hear if one county thinks of a policy from DHS in this way and another county interprets it this way. That's really valuable information to see and understand how it's being interpreted at the front line. And because when we can get that, that then identifies, okay, there's some confusion going on here. We can dig further into why that confusion is. Maybe the language needs some sort of updating, or maybe something was missed in the training that DHS provided, or we just don't know. We don't know what needs fixing until we understand more about the problem. And hearing from everyone and creating a space where people feel comfortable to share that, that can't be undervalued as well. It's not noted here, but all through this kind of approach is that, and we do safety a lot, but and so not to using that word, but creating a safe space, creating an environment where in a meeting or in a one-to-one interaction, someone feels comfortable sharing their perspective. That takes some work. And so it's not that you can just grab these and do them. Sometimes there's some infrastructure and some capacity building around that. But we've highlighted this about wanting to avoid only using counterfactuals when looking back at incidents. As Charles noted, sometimes part of that first story and something that does need to happen is that we need to identify what was expected. And so we want to do that, but we caution not to stay at that. As it says with kind of the arrow there, is we want to go beyond should haves or would haves, and we want to focus on what did happen and why. Through our language and through our approach with recognizing counterfactuals and hindsight bias and some of those other biases, we want to do our best to avoid blame. Trauma-informed kind of approach, we do talk about incidents happening to both people and the workers, and not because of them. So we really truly believe that and take that within our approach to reviewing incidents and encourage others to as well. Start by assuming that staff had good intentions, that they were trying to do the best they could in the circumstances that they were in, with the knowledge they had, with the pressures they were facing, and use that approach until you're further proven otherwise that they were acting upon bad intentions. Because, like we said, blame it can narrow our scope into thinking, well, this is just A led to B led to C. This is a very linear approach to thinking when we engage in blame. So we want to move beyond that. We want to try to access some of those pieces of local rationality that we talked about. Again, that's attention, focus of attention. What was staff focused on at the time of the incident? What were they trying to achieve? Where might they have been coming up with some conflict between kind of policies or expectations, or in the moment, person was wanting one thing and their plan of care said something different. That's those strategic factors, and then the knowledge factors. I think many of us are used to kind of considering knowledge factors. And so it's still important to explore and see whether that's a part of that. And then I put a little asterisk on the last one. We use this last one within our incident review model because we're studying it from a global kind of statewide. How can we gather data to inform our service system? So there we're trying to analyze the system, and we're not trying to fix the individual incidents as we work on this statewide efforts. And so I put the asterisk there because depending on your use of this science and information from this training, you might want to study the system at your kind of local, your scale, within your agency, within your organization. And you probably do need to address individual incidents. You might need to understand, oh, these things keep happening, incidents keep occurring. So you might be exploring the system within that, but also need to address and fix or help with specific incidents. So it applies, but I want to give that caveat that it depends on where you work what you do and what you're dealing with overall and on a day-to-day basis. Because we know as a provider, you are expected to look at incidents. I mean, you do have that lens. We talked a little bit about biases. So here's some more definitions to just clarify that the understanding of hindsight. We should have had outcome here, but we talked about it before. Severity bias, that can be a big thing that is tied to outcome as well. And then proximity bias too. The people kind of closest to the outcome or closest to the work will sometimes have maybe a bigger reaction or a different reaction from someone further away from the work. And biases, we always talk about this in some of our other trainings too, is like we're always going to have biases as humans. It's just how we see the world, how we make decisions is based on past experiences, knowledge. Um, that's how our brains operate. And so our biggest thing with bringing awareness to it is the recognition, like, is this changing how I'm approaching how our organization is responding to this? Is this changing what we're looking for? And if so, like checking that and trying to figure out how we can reduce the impact of those biases in our processes. These last few slides give you a little bit more about the local rationality piece. So give some questions. These questions aren't written in a way that you would want to directly use them with staff, but they give you some ideas of, well, what would we be trying to look at if we were trying to learn more information about attentional dynamics. So some examples here. What was the worker's focus of attention? And the last one, what constraints, pressures, or demands influence the worker's focus of attention? This allows you to dig into more about this area. Here are these strategic factors. So we talked about goals or competing goals, how they were prioritizing tasks. So some examples to kind of help you think about questions or thoughts on incorporating this into some of your questions in response to an incident or how you think about what's going on. And then lastly, some knowledge factors. So yeah, what informs a worker's decision? What sources of guidance are most important to a worker? Might be really specific about has the worker had the training that is required? Because sometimes what we've learned is staff do have training available to them. Staff or providers have required training processes set up, but if they're short-staffed, sometimes they get part of the training or an abbreviated version, and then they're working within some veteran kind of staff supporting them with some shadowing or some checks, and sometimes there are some gaps in those knowledge factors. So exploring that is good to do, and consider then, from here, as you gather that information about local rationality, this as an organization or an individual gives you more information to say, to start to explore if you need to explore it at a systems level, or if this gives you enough within your agency to say, I'm seeing some trends over time here that we're constantly having our staff kind of running into some issues back and forth between these two policies. Maybe we need to address something here. So that's the majority of what we have here. We've got a few last things to share would be we will send a training survey out either yet this week or should be next week, one of the two. That'll go out to participants asking. It's a short survey asking for, I think it's about 4 or 5 questions, asking for how you experienced the training, how did it go. We do have a question if you're interested in more training. We made reference to a longer 2-day training that builds upon this orientation. It includes this orientation, but it includes some more specific content around how to engage people, how to create an environment where you can get more information. So feel free to fill that out and share some of your thoughts there. The last piece is a link within the PDF that's about videos and resources. So Collaborative Safety, the organization we've referenced, they've got some great videos about safety science, really short kind of nuggets. We haven't created any of our own real-time videos, on-demand videos like they have. So that information is linked there. Their website's there at collaborative-safety.com. That survey, yeah, will be sent next week. And I guess the last actual content is just a couple of reminders. These both align really well with they're good pieces of information. First one's kind of comical, TV series on Apple TV called Ted Lasso. He has lots of good one-liners that, in general, if you have seen it or even if you haven't, he's a soccer coach who knows not much about soccer, but does a good job creating an environment where his players feel where his players can best succeed, where he listens, and in general, he kind of put out this notion: be curious, not judgmental. And we talked about that of trying to wear a curious investigator hat and not immediately judge. And Albert Einstein had a quote talking about if you had an hour to solve problems, he'd spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. So reminding ourselves that if we can have the ability to learn more, spending time and thinking more is really helpful. If I had any caveat to his quote, I'd say, well, we probably need more than 5 minutes about solutions, but we certainly we don't need any. We don't want to flip that at all and just assume we know the problem and jump to solutions. We want to engage in where we can in learning some of this great information from the people that do the work to inform our change. So I didn't leave much time for questions or comments, but we can probably stick around for a couple more minutes if anyone does have any specific questions. Otherwise, our kind of our email is listed here. We haven't updated the kind of first part of it. We started our project, as I mentioned, by a name of Collaborative Safety. Now we use Culture of Safety, but if you need to get in touch with us with any follow-up questions, feel free to do that. We'll send a survey next week. So we'll hang out for a few more minutes, and thank you all. Over 100 people that came to this training. We hope you picked up something that can help your work and your efforts, and we thank all of you for everything you do. And we hope to see you again in the future.